This is Med School Radio. Welcome back to Med School Radio. This is Simon in Tokyo. And we are back. We're going to be talking about the heart, atherosclerosis this time, looking at some MCQs from osmosis.org. So let's get right to it. Some of this may be familiar to you, some of it not, but it's really great practice to read some questions and test yourself before you take a test. Okay, here is the first scenario. A 55-year-old African-American man comes to the ER because of sudden weakness and numbness on the entire right side of his body. Medical history includes atrial fibrillation, remember that, and type 2 diabetes mellitus. Examination shows diminished motor strength and sensory deficit in his right extremities. He is unable to follow verbal or written commands and repeat phrases. His speech, however, is spontaneous and of good quality. Which of the following is the most likely cause of the patient's symptoms? So here are the choices. A. Intracerebral hemorrhage of the middle cerebral artery due to poor sugar control. B. Intraparenchymal hemorrhage due to rupture of the lenticulostriate muscles. C. Intracranial hemorrhage into the subarachnoid space from disrupted vessel wall integrity. D. Ischemia caused by blockage of the left inferior division of the middle cerebral artery. Or E. Ischemia caused by blockage of the left superior division of the MCA. Okay. So the answer here is D, ischemia caused by blockage of the left inferior division of the MCA. The major takeaway here is ischemic stroke is commonly caused by embolic disease due to atrial fibrillation. Another significant cause of ischemic stroke is atherosclerosis. Right-sided motor and sensory deficits are caused by contralateral left-sided cerebral involvement, which can include Wernicke and Broca areas. I know you've looked at atherosclerosis so many times, but it's a good idea to take another look at it so that you'll recognize why this happens. So, the main explanation here is the patient is experiencing a classic presentation of ischemic stroke involving the inferior division of the left MCA. He has sudden onset of right-sided hemiparesis and sensory deficits, as well as Wernicke aphasia. Wernicke aphasia, if you remember, is a receptive type of aphasia that results in the inability to read, write, and repeat sentences with poor comprehension. Fluency, however, is intact. Patients are unaware of their language errors, as the speech is preserved but the language content is not correct. The incorrect language content can range from insertions of non-existent or wrong words to a profuse jargon usage. Other symptoms of stroke include the inferior division of the MCA, which includes contralateral homonymous hemianopia or apraxia. The patient's history of atrial fibrillation should raise the suspicion of an ischemic stroke brought on by an embolus originating from the heart. Patients may also have a history of diabetes and hypertension, which are also considered significant risk factors for stroke. And lastly, diagnosis of stroke initially involves non-contrast CT imaging. If imaging shows no hemorrhage, consider aspirin. Patients already on aspirin regimen may be given clopidogrel, ticlopidine, or dipyridamole. So there we have it, our first MCQ. Let's take another one. A 31-year-old man comes to the office because of chest pain with activity for the past 6 months. He is a businessman and he says that his job is stressful, but has not been more stressful than usual. He has diabetes mellitus. Examination shows a BMI of 28.5 and blood pressure of 137/83. Coronary angiogram shows 75% narrowing of the left anterior descending coronary artery. Which of the following risk factors is most significant for this patient? A. Diabetes mellitus. B. High carbohydrate intake. C. Lack of exercise. D. Obesity. Or E. Stress. So the answer here is diabetes mellitus. The major takeaway here is atherosclerosis can be caused by diabetes mellitus, especially in younger patients. Diabetes complications can be grouped into macrovascular. We're talking about ischemic heart disease, cerebrovascular disease, and peripheral vascular disease, and microvascular, which would be neuropathy, retinopathy, or nephropathy complications. The main explanation is this patient has multiple risk factors for atherosclerosis, and as a result has developed ischemic heart disease, specifically stable angina. Of the risk factors in this question, diabetes mellitus is the most significant. It is a proven risk factor for the formation of atherosclerotic plaques and can be a cause of extensive vascular disease, even in young people. Most of the pathologies associated with diabetes mellitus are a direct result of this vascular disease. When large vessels are affected, it results in ischemic heart disease, for example, a heart attack, cerebrovascular disease, for example, a stroke, and peripheral vascular disease. And we're talking here about claudication or arterial ulcers. So when small vessels are affected, patients may develop neuropathy. We're talking about nerve disease, retinopathy, which is diabetic eye disease, or nephropathy, chronic kidney failure. So lastly, the mechanism by which diabetes is thought to induce atherosclerotic disease is through hyperglycemic damage to the intimal layer of the arteries. Okay, remember it's the intimal layer of the arteries which is damaged here. That was a very good MCQ. We learned a lot there, I think. Okay, next. A 57-year-old man comes to the office because of pain in his legs while walking. The pain starts in his buttocks and extends down his thighs into his calves. Previously, the pain disappeared with the cessation of activity, but lately it persisted in his feet, even at rest. Medical history includes diabetes mellitus, smoking, and hypertension. Examination shows atrophied legs with bilateral loss of hair. Which of the following is the most likely etiology for this patient's leg pain? The choices here: A. Decreased permeability of endothelium. B. Narrowing and calcification of vessels. C. Peripheral emboli formation. D. Thrombus formation. Or E. Weakening of the vessel wall. So there are a few here that I might think about, but the answer is narrowing and calcification of vessels. The major takeaway here is that peripheral vascular disease is caused by narrowed and calcified vessels. This leads to muscular ischemia during exercise, which is perceived as cramping pain that begins proximally and extends distally. This patient suffers from peripheral atherosclerosis, a chronic inflammatory disease of blood vessels that involves the accumulation of lipids within the intima, recruitment of leukocytes and smooth muscle cells in the vessel wall, and deposition of extracellular matrix within the arterial wall. The resulting atherosclerotic plaques can cause narrowing and calcification of major arteries. Flow-limiting atherosclerosis in limb arteries often presents as claudication, which is crampy limb pain resulting from muscular ischemia during exercise due to narrowed arteries. Symptoms of limb claudication are namely buttock, thigh, or calf pain precipitated by walking and relieved by rest. Vascular risk factors are an important clue to diagnosis. So lastly, this patient is a current smoker, is hypertensive, and has diabetes mellitus. All of these factors damage or facilitate damage of vascular endothelium. So this one talked about peripheral vascular disease, which is another commonly tested point. Okay, let's try another. A 60-year-old man comes to the ER because of acute painless loss of vision in his left eye that came on early that morning as he was going up a long flight of stairs at home. He says that he cannot see at all with his left eye, but his right eye is unaffected. He is currently taking atorvastatin and enalapril. A fundoscopic examination is performed and it shows that his left pupil dilates slightly when light is passed from his right to left eye. His macula is well perfused, indicated by the presence of a bright red spot at its center. But there seems to be a bit of hazy translucency of the retina otherwise. Which of the following is your suspected mechanism of injury? Okay, there are 5 choices here. 1. Congenital arteriovenous malformations. B. Glycosylation of retinal blood vessels. C. Blockage of the left central retinal artery by cholesterol embolus. D. Marcus gun pupil, resulting from a fall down the stairs. Or E. Closed angle glaucoma. The answer here is a blockage of the left central retinal artery by cholesterol embolus. And the major takeaway is ocular ischemic syndrome is the constellation of ocular signs and symptoms secondary to severe chronic arterial hypoperfusion of the eye. There's a lot of information we're talking about here, but if you take the time to go through these questions, especially before a test, you're going to do really well on the test. So there's one paragraph of explanation here. I think I'm going to read it. The main explanation: this man is presenting to the ER with what is likely a cholesterol embolus, occlusion of his left central retinal artery. The diagnosis is suggested in his history: a sudden onset persisting painless loss of vision in an older man who has existing hypercholesteremia and hypertension. Older age, male gender, hypercholesteremia, and hypertension are 4 major risk factors for atherosclerotic disease and subsequent cholesterol emboli, especially during increased work, such as climbing stairs. Furthermore, on fundoscopy, the man has a well-perfused macula, which was the cherry red spot, which is served by the choroid vessels, while surrounding retina, served by central retinal artery, is not well perfused. There we have it, another great MCQ. We have the little girl upstairs running around, making lots of noise, which is great practice for me concentrating on tests, because it can't always be quiet. Okay, let's try another one. A 75-year-old man comes to the primary care clinic because of tea-colored urine for the past 2 weeks. He has been feeling more fatigued for the last few weeks, but denies any other recent changes. He has a history of hyperlipidemia and insulin-dependent diabetes mellitus, as well as a 40-pack-a-year smoking history. His blood pressure in the room is 201/95. Urinalysis shows 3+ protein and red blood cells. A retinal biopsy is obtained and shown below. A renal biopsy is obtained and is shown below. You can see this. Which of the following is the most appropriate medication for this patient? The choices here: A. Albumin, C. Cisplatin, C. Dexamethasone, D. Epoetin alpha, or E. Labetalol. And the answer is labetalol. Major takeaway, hyperplastic arteriolosclerosis is a characteristic onion skin appearance on biopsy of arterioles. It is associated with hypertensive emergencies, which are treated with multiple antihypertensive medications. So let's make sure we're presenting this and pronouncing this correctly. It is hyperplastic arteriolosclerosis. So we're talking about the arterioles. This patient has hyperplastic arteriolosclerosis confirmed by biopsy. And arteriolosclerosis simply means hardening of the arteries, of which atherosclerosis is the most common subtype. So the key here is this onion skin appearance on the biopsy, which is indicative of a severe, relatively acute increase in blood pressure. And the increase in blood pressure is known as a hypertensive emergency, which was previously known as malignant hypertension, and is defined as hypertension with a systolic of greater than 180 or diastolic of greater than 120 with acute impairment of one or more organ systems, especially the central nervous system, cardiovascular system, and or the renal system. Treatment for this hypertensive emergency consists of multiple antihypertensive agents. The choice of agent depends on the etiology of the hypertensive crisis, the severity of the elevation in blood pressure, and the usual blood pressure of the patient before the hypertensive crisis. In most cases, the administration of an intravenous sodium nitroprusside injection is best because it has an almost immediate antihypertensive effect. Often it is unavailable, so in less urgent cases, oral agents like captopril, clonidine, labetalol, or prazosin can be used, but all have a delayed onset of action by several minutes. Okay, so we're going to do a few more. We're just going to give the basic major takeaway here. So here's the stem. An 85-year-old woman comes to the ER due to temporary loss of vision in her left eye. History reveals the patient had a 5-minute episode of visual loss and describes it as if a shade was pulled over her eye. Past medical history reveals hypertension and diabetes. Neurologic and ophthalmologic examinations are normal. Which of the following is the most likely cause of this condition? A. Alcohol. B. Long history of smoking. C. Hypertension. D. Atherosclerosis. Or D. Diabetes. And since we're talking about atherosclerosis, you can imagine that's what the answer is. The major takeaway: transient vision loss, also known as amaurosis fugax, is the subjective phenomenon caused by a transient and temporary ceasing of retinal blood flow, most likely due to atherosclerosis of the carotid arteries. Okay, just a few more questions here. A 65-year-old man comes to your office because of pain in the lower extremities. The pain is associated with walking and relieved by rest. He has a history of myocardial infarction, hypertension, hyperlipidemia, diabetes mellitus, and smoking. Examination of the legs shows atrophic changes with diminished pedal pulses. Which of the following is the most appropriate initial treatment? A. Clopidogrel. B. Metoprolol. C. Pedal pumping. D. Revascularization of the extremities. Or E. Smoking cessation, exercise, blood sugar, and hypertension control. The answer is smoking cessation, exercise, blood sugar, and hypertension control. The major takeaway here: intermittent claudication due to atherosclerosis and peripheral vascular disease should be first managed with conservative therapy. And this will aid correction of the underlying pathologies. So So that was the last question in this series. Thanks for tuning in. We were looking at osmosis.org, and as I was saying, I often go through these MCQs prior to tests or before I start a new unit or a new week, new topic, etc. So thanks a lot, and we will see you again soon.